All right, thank you, PK, for the invitation. It's been 18 years since I've been here when I did medical residency, so good to be back. All right, so I was told to talk about crossing and reentry device use, preference versus rationale. A little bit ambiguous title. Here's my disclosures. So what I thought we'd talk about is basically, fem-pop occlusion. Your strategy is going to depend on a couple of things. First is the clinical situation. Is this a claudicant or is this a critical limb ischemia patient? And that might adjust your level of aggressiveness. Anatomy, so occlusion sites. What are the proximal and distal caps like? Are they calcified? What are the shapes? Is there big collateral coming off of it? How much runway you have? What's the proximal and distal anatomy? So do you have hostile groins, steep iliac bifurcations? Do you have 3-vessel runoff or no vessels? Lesion traits, so the length of occlusion, how calcified it is, and of course operator experience, how comfortable you are with crossing catheters, reentry devices, retrograde access. So this was the CTOP classification that was recently published by Mustafa and his group, looking at the cap shape and how that determined whether a antegrade, retrograde, or hybrid approach was necessary. And you can see why there's so often the need to use reentry devices or retrograde access, especially in 2, 3, and 4 CTOP classification. So you already heard this from the previous speaker, how CTOs are very, very common, and we need to get across these to have the best outcomes. CTO devices can increase success rate, but adds additional cost. Retrograde crossing can also increase success rates. So here's a smattering of the crossing catheters or CTO devices. You can see that they all basically use some sort of energy, whether it's mechanical. The true path is like a spinning wire with diamond grit on the tip. Front runner with blunt dissection, crosser using ultrasonic activity, wildcat, again, mechanical, and Viance, as PK is using in this case. Ocelot is like the wildcat, but with OCT guidance. A newer one that I have not had the chance to use yet is the Houdini catheter from Cruiser Med. This is a balloon that has the ability to evert at the tip by advancing this plunger in the back, and that will advance your guide wire as well. So I just put these in for your reference if you can download these for more details on the crossing catheters and reentry catheters. But this is a type 2 CTO from the CTOP classification. You can see why it's so often that we go subintimal, whether we use wire catheter or a CTO device. So reentry devices, I think, are very valuable, and it's good to become familiar with at least 1 or 2 of these. You have the Off-Road, the Outback, the Pioneer, which is similar to the Outback but using ultrasound guidance, and then the Interior, which is the sort of stingray balloon that orients itself such that you have a wire port that can re-enter distally. And again, all of these somehow employ a hypotube or needle or a wire to puncture it back into the true lumen distally. Now, even with that, and sometimes before that, you can go retrograde. So retrograde access to CTOs are, I think, a necessary skill set, especially dealing with critical limb ischemia. And sometimes, even with retrograde access, you need to use reentry devices to pop into the balloon from below. So this is reentry assisted fenestration. You can see on the left the more standard usage of an Outback catheter with the L pointed towards the distal reconstitution point. On the right is a critical limb ischemia patient where there was no reconstitution, so we put a balloon up retrograde, and eventually we're able to puncture the needle into the balloon, passing the wire into the ruptured balloon, and exteriorizing that wire to get through and through access. Sorry, it's playing real slow. All right, so real quick, the strategy. I wanted to talk about CTO. You can go wire-based or crossing device-based. Hopefully getting through would be best, but if you're unsuccessful, you can either go to retrograde access or go to a reentry device at that point. If you go retrograde access, you can also use the same techniques, wire-based or crossing catheter, depending on your sheath size. And then if you still don't cross, you can do advanced retrograde, antegrade, retrograde crossing techniques, such as double balloon fenestration or the reentry assisted fenestration, reverse cart techniques. You can do the same thing if you start retrograde. So I'll show you a case next that we decided to go retrograde first. But retrograde first, you can still use crossing catheters or wire and catheter. If you're unsuccessful, reentry device or come antegrade, and again, using your double antegrade retrograde crossing techniques. So this is a 71-year-old gentleman with a previous fem-pem bypass, severe claudication in the right leg with an ABI of 0.5. You can see the angiogram shows a flush occlusion of the right SFA with reconstitution in P1 segment of the popliteal artery and good two-vessel runoff with a very large anterior tibial artery. So would you use crossing devices here, or would you use alternative access? Would you go antegrade, retrograde, or be ready for reentry? So in this case, because of the flush occlusion, we decided first access to go retrograde from the anterior tibial approach using a small sheath. We got up to the common femoral artery where we were subintimal with the support catheter. So the question is, what next? So we use a lot of ultrasound-guided intervention in our lab. You can see on the right, this is a different case, but a case where I'm pulling back an angled navicross catheter after I'm subintimal, and I can see where the SFA origin is. I angle it, and I aim my catheter right at it and push, or use a non-hydrophilic wire at that point to try to puncture it back in. If that doesn't work, though, like in this case, and sometimes with surgical manipulation, the scar tissue is a little harder to re-enter, we upsized our sheath to a slender sheath and used outback to puncture back into the common femoral artery. We exteriorized the wire so that we had through-and-through access, and deployed drug, Zilver PTX here, actually from a retrograde fashion, so we can land it very accurately. And so that's just a case of alternate access and alternate devices. So CTOs are very prevalent in our PAD patients. Being able to cross these lesions is important in determining the patient's outcome. Judicious use of alternative access and alternative devices can be important in achieving this with the least amount of risk and cost. Thank you.